than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Good morning, good afternoon, and good evening, ladies and gentlemen. Welcome to the SICOT Pioneer webinar series. I'm Dr. Margaret Fogg from Hong Kong, the chair of the SICOT Education Academy. Before introducing today's chair and faculty, I would like to share some background on the SICOT Pioneer initiative. SICOT Pioneer is part of the SICOT Education virtual platform, which launched in June 2020. Since its inception, we have organized 94 webinars and 7 tete-a-tete sessions. Today is the number 101. To date, the platform has granted over 47,000 live views and another just under 80,000 on-demand views. We are also proud to have a Pioneer fan club of over 10,300 members. If you would like to explore our previous webinars and other educational activities, please visit the SICOT website at www.sicot.org. We encourage you to join as a member to access these resources on demand. Today's webinar is co-organized by our SICOT Hip Arthroplasty Committee and the APOA Asia Pacific Hip Society. It is about the use of 3D printing in complex hip situations. Our moderators are Dr. Nicolás Restrepo from Colombia, who is our chair of the SICOT Hip Arthroplasty Committee, and Dr. David Choon from Malaysia, who is the Education Committee Chair of the APOA, as well as the past president of the Asia Pacific Hip Society. So without further ado, I'll now hand over to our moderators, Nicolás and David, to begin the session.
Thank you, Margaret. It's an honor to join in this webinar with the Asia Pacific Society and with these extraordinary speakers. I give the words to Dr. David Choon from Malaysia. Thank you, Dr.
Thank you, Nicolás. Greetings from the Asia Pacific Orthopaedic Association. The Asia Pacific Hip Society, which is Society of the Asia Pacific Orthopaedic Association, which was founded in the 1990s, is strongly represented here today. I am a past chairman, and Louis is the current president, and Abhay is the president-elect. Vishnu Senthil will probably rise through the ranks one day, and he's going to be starting off introducing the topic to us, which is 3D printing and how it can be used and optimized in our surgery. Vishnu?
Yes, sir. Thank you for the introduction, Professor David Choon. And yeah, I think everyone can see my slides. So the topic is 3D printing in arthroplasty and how to optimize its resource. So normally we use the 3D printer. So normally a printer prints the normal page, and 3D printing instrument or the appliances prints whatever we want and whichever we use. So initially the 3D printing is generally two types. So it consists of two components. One is the rapid prototyping, where the image, whichever of the concerned part or the concerned thing or organ to be printed, is converted into a computer-aided design file, and later it is printed in successive layers. It's called as additive manufacturing. So this is the basis of any 3D printing technology. So coming to the history, it nearly took 2 decades from the birth of the 3D printing mechanism and the 3D printer to the availability of the technology to the market. And now it is widely available all across the world, and even in low middle income countries and also the Asia Pacific countries, where it is commonly available and where its importance is being noticed and it is being taken into consideration. So initially in 1983, Charles Chuck Hull from Hull found the co-founder of 3D system. So he found called as stereolithography. And the first printed material was a eye wash cup in 1983 with the help of a 3D printer present at those times. And slowly the 3D printing has been reformed, where till now we were able to print complex models and even also print complex, even for organ systems also it is being used. So in 1989, Scott Crump, co-founder of Stratasys, found the fusion modeling technology, which has been the basis for our current 3D printing mechanisms. So initially in history, it was initially used for printing of human anatomy models, which is how it developed. Then slowly it went in preparing for surgical planning. So it was commonly used in dental implants, oral maxillofacial surgical this. So in 2008, the first 3D printed leg was done, and 2012, 3D printed jaw system was used in Holland. So coming to our orthopedics and especially hip, so where it is used. So it is primarily used in the acetabular side to form in primary and revision cups, and then also in special case scenarios where when we are using complex reconstruction of the pelvis or in tumor reconstruction surgeries. So it main uses in usage of surgical guides. So it was used in spinal deformity correction and also in pelvic acetabular fractures, surgical instruments, patient-specific implants, where you can use titanium cups, and also help in additive technology or use additional of biointegration, where it helps in good integration. And it's also used in periprosthetic infection, where antibiotic-coated PLA implants are used instead of PMMA cements for controlling of prosthetic joint infections. And finally, in regenerative technology, where it helps in regeneration of cartilage and other issues. So this is a review article where they are done about multiple 3D cups and 3D imprinted implants. So in subsequent talks and case discussion, our different various speaker will introduce the 3D printing, how they have used it for their complex scenarios. So what is the use of 3D printing? So it is mainly used in the virtual planning phase. So we have an image from the CT, then we convert it into a computer image, and from the computer image, you can do the virtual planning. So where you want to do what. So even in India, which is a wide population state, and we have a well supported, so the government nowadays having the importance of 3D printing. So initially it was in the engineering college for the 3D printing. Now the government is having a lot of funds allocated. So the 3D printing is widely available in all teaching institutions. So it can be widely used for all complex cases. So that is the importance of 3D printing technology, which is being utilized all over the country. So what is the basis? So initially you have the DICOM image, where the DICOM image is converted to a 3D model using formation of the STL, that is the stereolithographic image or the computer aided design image. So in this image, you can do the virtual surgical planning where evaluation, manipulations, calculations, corrections, design implantations, everything. And finally, the model is printed with the help of rapid prototyping and additive manufacturing. So for this, you need various softwares. Now, most of the softwares are available free to the public and everywhere to the institutions, where the different images are converted into a 3D printing image where it can be converted to 3D printer. So this is a 3D slice CT scan, which is converted into a CAD computer aided design data or the stereolithographic file. So this is how it has been converted. And this is how the 3D printer looks. It's a demo printer where you demo for 3D printer where you can, whatever you want, you can print. And how the printing techniques are there. So now commonly used is the fused filament fabrication, where the plastic is used commonly in additive layers where the metal is extruded. We have various type of printing techniques like the photopolymerization, powdered bed fusion, and binder jetting, material jetting, and ink printing. So the most common is used as the fused filament fabrication or the FFF. So this is how the 3D model, which is 100% of size. And from this 3D model, it can be used for academic purposes, planning purposes, and even for students or medical graduates where they can plan. So this is how we help them to plan how to print and how to place the cups. So it can be a well educational platform before going into a surgical scenario. So this is how we print for complex scenarios. We can print individually and plan for the surgical this. So future in various speaker will tell about the various cases scenario. So the primary this is where you have the segmentation, and it is mostly used for the defects. So since it is a hip topic, it is help in defects, mostly in Paprosky 3A, 3B defects or pelvic discontinuity. So the preoperative planning to determine the center of rotation, inclination angle, anteversion angle, and when you have the printed model, you can use it whether you can have a bone grafts, allografts, or augments. So whichever in an armamentarium, so proper preoperative planning is the key from the 3D printed models. So these are the various custom-made implants which are used for different patient-specific. Then you can also use patient-specific instrumentation, use jigs to cut for specific, for a tumor resection, you can use to cut and try to implant the processes. So all virtual printed jigs, guiding arcs, it has been used in knee and various other conditions. So why 3D printing? It helps in better visualization, understanding, and preoperative preparedness, and it helps to customize your operation, customize your implant, your armamentarium, and also helps in personalization, enhance productivity, accuracy, and cost efficacy is also nowadays it doesn't cost very much for 3D printing, and also the most important is better medical education and a good doctor-patient relationship where you can explain to the patient, so this is how we are going to, this is your defect, so this is how we are going to implant your this, and this is how we are going to plan. So the patient will have a better confidence on the doctor, and it helps in a good interaction between the doctor and the patient. So other applications in arthroplasty, spine surgery, custom-made orthotics, implants, complex trauma, patient-specific instrumentation, and it can be used wherever you want with the help of this technology. So disadvantages from literature, there is a risk of infection because of the sterilization, autoclaving processes. So the rate of infection is high, and different porosity of the implants encourages the biofilm formation. So that has to be kept in mind. So good sterilization techniques, intraoperative placement, everything is to be taken care like any other implant you are placing it. So what are the limitations? The limitations and the challenges are exposure of the 3D printing technology, standardization of the procedure, guidelines is needed, definitely a manpower training is needed So cost related to the manpower and cost related to the acquiring the resource and keeping the resource in this. So maintenance cost, technical demand. Definitely there is a time constraints because you have to take the 3D scan and you have to print. So definitely time and cost restraints are there depending upon the area where you come from and the practice which you do. And definitely interdepartmental collaboration is definitely needed to help in facilitating the process and have a good communication so that you can have the implant or the design so which you want with a good interdepartmental collaboration. So coming to my conclusion, I have dealt in the introduction, the development, the history of and how to develop a 3D model where the CT scan is converted to any computer-aided design with splicer technology. And finally, you have the 3D printed models which can be used for a surgical virtual planning and for the intraoperative planning. Definitely, there are various advantages and limitations too are there depending upon your scenario from your country. So take use of this technology and do implement it in complex scenarios to have a well-defined case success rate. Thank you, and thank you for the opportunity. So do fill our post webinar and thank you.
Thank you, Dr. Vishnu. From our part, from SICOT part, you have as well as Asia Pacific, an excellent, a luxury panel. Begin with Vishnu. Vishnu is part of the HIP subcommittee. Dr. Olga Pidgaiska is an excellent orthopedic surgeon from Ukraine, right now working at a charity hospital, part of our subcommittee. And we continue with the excellent talk of Dr. Oliver Marin-Peña. Dr. Oliver Marin is an excellent hip surgeon from Madrid. Right now is the past president of our SICOT hip subcommittee. It's a well-known surgeon and the vice president of the Europe region from SICOT, and is in charge of the excellent meeting in September, the OWC meeting in Madrid. And we are hoping that this talk will be excellent. It's 3D printing and new technologies applied to massive acetabular osteolysis. It is really helpful. Go ahead, Oliver. Thank you so much for joining us.
Thank you, SICOT, for the opportunity to share with you this presentation. Thank you for the invitation. Of course, Nico, you are very welcome in Madrid next September from 3rd to 5th in this wonderful meeting with more than 3,000 people sending abstracts. So my presentation is not so theoretical. So I will present a case-based presentation, and I really appreciate if you guys can collaborate in the discussion of the case. So these are my conflict of interest that do not affect the following presentation. So this is the case. This is a 71-year-old patient with some important limitations, including actually walking long distance with a wheelchair. He has 3 centimeter right limb shortening. He has he had a total hip replacement in the right hip 30 years ago in Venezuela. So he's a very nice guy and come to our clinic with this problem. And these are the x-rays. So this guy present this interesting view in the AP and axial. The pain was in the groin, and they have some limp, and also limitation of the range of motion. So, guys, any comment on this X-ray? Do you have any specific comment about this image? I know there is a deficiency, bone deficiency here, but Vishnu, for example.
3A defect.
Yeah.
So it's an up and out defect, and this will need revision. And up and out essentially means the center of rotation is more than about 2 centimeters proximal. It's medialized, proximalized, and you will have some degree of ischial osteolysis, probably less than 15 millimeters. And you might have some osteolysis at the proximal greater trochanter. So not only will it need a acetabular reconstruction, it will need the revision of the femur, unless it is very well fixed.
Yeah, a revision of the femur. That's interesting, Nico.
For all the people, Dr. Abhay had a good topic, but it's important for all people, new people who are beginning, that this massive osteolysis probably could be prevented if you have a proper follow-up. The people is from Venezuela and you're in Spain, but I suggest that all my patients have at least an X-ray every 2 years and a consultation every year. Just in case you have an osteolysis, you can determine if you need, if it's progressive and have problems, you can begin with the revision properly and easily and quickly and with this massive defect.
Yeah, Olga, any comment on that? Because I know you are in Charité, so you are always thinking about infection, and I will tell you that all the parameters are normal. So
no parameters, but what about hip function? It's also be quite informative, and I think from these X-rays, it could be not so easy to get into the joint. I mean, to aspirate some fluid, because I see it's not so much space between femoral neck and the head, but nevertheless it's one of the options. They have to always check the hip function. And as for, what about pair friction between the pair friction? Is it like ceramic poly?
Yeah. I mean, great question, Olga. This is a ceramic head and polyethylene. That's the couple variant. Yeah.
Just to be sure that it would not be metal on metal, this kind of so the tumor that we have to take care.
So,
and definitely CT to see about pelvic discontinuity of the upper and the lower part of the pelvis. Is it still connected?
Thank you. This is what was my question, Olga. Do you ask for any other exams? So as you mentioned, we did a aspiration. To be honest, only a couple of centimeters come from there, so not very useful. But no any growth in the cultures, and all the lab tests were negative for infection. We also asked for metal ions, as you mentioned. Sometimes you have some kind of metallosis, and chrome and cobalt were normal, right?
Yeah.
And my question is, if you ask for another, other image, and you mentioned CT. So anyone ask for MRI in these cases, or any that makes sense?
From my point, no. CT is quite enough. Moreover, you can see on the CT also in the regime some soft tissues. I would not. For me, we can use it, yes, and as additional option. But for me, I think it's quite. If I won't see any suspicions on CT, like some kind of fluid formations, so I won't go for MRI. CT would be quite enough.
The MRI would be very important as far as I'm concerned, because for two reasons. One, it will help show metallosis, and second, it will tell us about the extent of soft tissue involvement, which is very, very important. The one reason why these reconstructions will fail, despite very good metalwork, is very poor soft tissue. So I need to know both, and I would get an MRI. And I would need a metal artifact reduction sequence.
Great comment. So we did a CT, and these are the images of the CT. So you can see it's a huge bone defect, but it looks like there is no discontinuity at this point. Looks like sometimes it's not easy to see with the CT, but these are the right hip situation right now. Remember, chrome cobalt negative, normal, lab test for infection negative, and we have this huge defect here with not pelvic discontinuity at this point. That's the situation. So this is the 3D reconstruction of this guy, where you can see there is a continuous area, maybe some defect there, but it looks like a very thin wall medially that keep everything out of the pelvis, but probably nearly there. So any comment from your side with this CT? So
maybe from my side, okay.
Yeah,
I would need a CT angio.
Yeah, I would also ask for angiography.
Yeah, I don't have the images here. We did it, but and the vessels were not so close to this medial wall, but are there of sure. So these are the options that we keep in mind: resection arthroplasty, acetabular impaction grafting, revision acetabular component plus augments, revision acetabular component cap cage, or custom-made acetabular component. So, Vishnu, what do you choose and why? Very short reply, please.
I would probably choose the custom-made one because I think very massive defect. But the design of these prostheses, we need to be careful and then have a close collaboration with the engineers, because I think all the options are feasible. I think, but I think this is a difficult exam revisions, so probably I would choose the custom-made one.
Okay, Abhay.
Yeah, so definitely a custom triflange implant, and definitely this patient will need an extended trochanteric osteotomy to get into the hip. So in any case, you would need to do a femur revision as well.
Good point. Dr. Choon?
You know, I'm the joker in the pack. I don't do this stuff. For my whole life, I've done lots of revisions just like this. It's absolutely stable. It's an enclosed and contained defect. I started my own bone bank in 1992. I still utilize it despite having left the university. I just use allograft and cement, and I've had a patient have this in for 15 years without any trouble. So that's just
a great option. It's a great option. I mean, in Europe we usually use that. It's a wonderful option. I think the other guys replay this custom made because we are in a webinar about custom made implants. But
But I would also use impaction bone grafting as David does.
Okay, so
it's a very nicely contained defect, and you find that it's very stable. The other problem now is that that cup has nicely made you a very round ball. And so anything you put in there has a chance of moving around unless it gets incorporated in some way. And that would be the difficulty. Also, getting it into that space is also not going to be so easy because it is a almost complete circle. So you have a small entrance and a big space or cavity above it.
Good point. Vishnu, what do you do?
Yeah, definitely I go for impaction bone grafting and custom-made triflange cup and if needed a cemented dual mobility.
Okay, Olga?
Okay, I would choose and thinking about, so as I see, its posterior wall is contained, anterior wall is also, we have some anterior wall to fix the cup. Maybe I would like to think about double cups, like a cup and cup, TMT cup, with combined with a impaction bone grafting here on the medial side defects. Sometimes when we use two titanium cup, it's cheaper than cup and augment. And other option, yes, okay, no, it would be like costly. How much does it cost? And also think about individually. So yeah, sure, why not?
Okay, thank you. Nico, you close the room.
You have all the options and you can choose all the options. I have two cases quite similar like this, with a big cavity and a small door. To create a custom made to fit this part is difficult. It's like put a muscle and like to use hemispherical augments to put inside and then put the tree flange or the custom made. It's easy, but another part that you can choose is the 71 guy. Apart this, just to discuss, is the cone hip, like the Lumi cup do have a steel part to put it inside. But there's an other option. I will do with the custom made.
Thank you, Nico. So I will show you what we did. I mean, all the options I think are great, yeah, that you mentioned. This is the plan of the defect. We measure 220 centimeters of the bone defect in this area. And we also discuss with the patient all the options, and all the options are correct. I mean, you can put huge amount of bone, augments, whatever structure that you are doing is correct, and if it's stable. But this is the plan, as Vishnu showed us before, they use for this kind of plastic models that can be prepared as a preoperative planning, but also to train about and this is the engineering planning of the proposal from the engineering. We change a little bit after the discussion with the engineering where they put the screws, because it's not easy with this defect. As you can see, there is like a wing that is going to the iliac bone, because it's the only bone that are completely okay to do the fixation, and also a peg to the isthmus of the iliacus, just to get stability. As you can see here, this is the model that we designed to complete fill in the defect. So in this case, there is a porous metal all around there. So try to avoid to put any bone, extra bone. This is the plan with the template in the plastic that we use intraoperative as well, just to put the position of the screws in this iliac wing. This is the printed metal with this porous metal in the areas that have contact with the bone to create a bone ingrowth later on. And this is what the screws should be there. And this is the intraoperative findings. This is the previous one. This is the ceramic. We use this Merete adapter to the cone, just to avoid any problem with the wear of this. And this is the position intraoperative. You can see that the acetabular component is completely free around, so we were very lucky. We don't need to remove it, and we don't have more bone loss than the one we have. It was very easy to remove it. And as you can see, no metallosis. We rim a little bit the beginning of the acetabular as recommendation of the engineering to adapt the final component in this area. And this is what we have. This is the bone defect. This is the plastic template, just to see we are following the pre-operative plan. And this is how we put inside. We don't put any bone graft, because with the porous metal we thought, and the stability we thought was enough. And remember that we have a peg going to the isthmus. So it was very important to put the component in the perfect position and following the guidelines from the engineering, and following our preoperative plan, just to avoid any mismatching of the screws inside. And we put the position correct of this acetabular component in the preoperative planning template. And this is the immediate postoperative X-ray with this screw and peg, who is with bone with this porous metal, and was perfectly stable with the screws in the iliac bone and in the ischium. This is some findings, and this is 4 months post-op. The patient we put a dual mobility cemented cap inside this structure, and this is the patient 4 months. The patient weight bearing immediately with 2 crutches in the next day, and the patient now is happy because was in the wheelchair and now can walk with some limp, because as Abhay mentioned, there was some damage in the gluteus that we repaired. But this is the case that I want to show you, and also invite you for the Madrid Congress in September. You are everyone welcome. Thank you, guys.
Excellent, Oliver. and you preserve the stem. Good surgery. Difficult.
Was fixed.
Yeah, excellent. We have a chat. If you have any question, you can put your question, and I try to share with all the participants. Dr. Choon?
Yeah, in Malaysia, actually, it was quite hard for us to obtain 3D printing. So actually, from our point of view in Malaysia, maybe we should go to India and study how you do it, Vishnu. It's actually custom made in India, right?
Yeah, we've got companies now who are doing it, and they're doing it for very nominal prices.
Yes. And
That's
even the
good.
government is supporting nowadays in helping to encourage the custom 3D printed implants in medical college setups to improve the patient care.
I think the better application for this is rather than revisions, is when you have tumor resections, you're really taking big chunks of bone out. And then you really need a lot more support in that case. And
Absolutely.
Tumor revision, tumor excision with 3D support would be excellent.
We will continue with Dr. Olga Pidgaiska
we should proceed
from Charity. Olga will talk us about the 3D printing to the reconstruct revisions and periprosthetic joint infection case.
Yeah. Good afternoon, good evening, good morning, everybody. And thank you for this great opportunity to be part of the SICOT webinar. It's a really nice and great honor. And today I would like to have a talk about some difficult cases where this combination of the severe bone loss, bone defects, and how they are combined with also with infection, and how we can manage them. So we know that all kind of infection, we are always aware of them, but nevertheless, when it happens, we are always worried, and sometimes it is a disaster. Because of that, it is quite important that these patients should be treated in the dedicated centers together with a close collaboration with the microbiologist and infection disease specialist, together with the surgeon as a multidisciplinary team. So from one side, when we have a huge bone defect, they are very often as a consequences of the polytrauma and as a consequence of the previous many surgeries, and very often accompanied with infection. And every time when we treat infection, we have to resect not only the dead bone, but also soft tissues. In such way, we create this dead space which can be filled with a hematoma. And we know that a hematoma is also like a good environment for the pathogen, and it's not so easy to manage with these huge dead space. And from other side, sometimes all the usage of the individual implants, it takes quite a longer time. It's combined with a larger bone or blood loss, longer time of operation, and it can be the rate of infection can be high compared to the primary standard implants, and can be like in a tumor surgery, this rate of infection can be exceeded up to 15%. Another topic, another problem that we have while dealing with these kind of cases is because of the previous many times surgeries, it could be the presence of the pathogen that are already resistant to some many antibiotics, and it could be very often difficult to treat pathogen like a rifampicin-resistant Staph aureus or the vancomycin-resistant Enterococcus, etc. Another problem that the presence of the biofilm. And when we are talking about 3D implants, we know that it's these implants, they have multi-layer structure and high porosity and the roughness, and it could be good environment also for the biofilm production. And we know when the biofilm are on the implants, it's really, they are quite resistant, 1,000 times more resistant to the antibiotics. And it's really difficult to eradicate them because they also can be found not only in implants, but also on the soft tissues. And for immune system, it's quite also difficult to clear the implants and this site from the infection. Another point that we have to take care about while treating patients with the previous surgeries. Very often, surgeons don't know or they cannot manage with the wounds, they cannot manage with the secretion, and they often apply a VAC just to stop these wound problems. And from one hand, it's good because it promotes like granulation tissues in growth, but from the other side, the new pathogen can be found after VAC therapy, and they are often like Enterococcus faecium, which is resistant to vancomycin. It can be Pseudomonas, which has a high rate of relapses, and also Candida as a consequence of the VAC very often, and it's really difficult for treatment. We need to like multiple debridements, and we followed with the suppression therapy. So in our practice, we follow the algorithm which was created, developed by Plant Foundation by Professor Trampush, and we use it in our practice for the choosing for 1, 2 stage or the 3-stage revisions. Now I would like to share some cases from our clinical practice, and these cases being followed happened because of the severe polytrauma complicated with the infection, and as a result we had a severe bone defects, and that's why we had to use these individual implants. I wouldn't list this huge number of the previous surgeries which had this young patient. She was treated in Ukraine because of the polytrauma, because of the multiple debridements, because of severe infection. But she came to the Germany with this situation of the spacer and the chronic fistula. And the first surgery, which we do all the time during these cases when the patient comes from other hospitals, we make a debridement. We just take tissue samples to know what kind of pathogen is inside. And in this case, you see that it was found polymicrobial infection. It was Streptococcus pyogenes, MSSA, and Klebsiella pneumonia, 3 MRG, and resistant to the 3 main groups of the antibiotics. So while making the debridement, we also saw this huge acetabular defect, and we were thinking about how to manage. You see this double tooth present put inside. We were thinking about how to fill this defect, maybe with the 2 cups. But afterwards, you see the patient had some wound disturbance. We had to evacuate hematoma. And for the treatment, she followed with the oral therapy with the cotrimoxazole and amoxicillin. And actually, we had, she took antibiotics for 1 year, and 1 year it took us for application of individual implants. I mean, for this kind of organization process, for about talking about costs, who will pay for these implants, how the government should pay for the Ukrainian refugees. And so it took us 1 year, but finally, not so long time ago, in May of this year, we used the individual implant for her and put a long revision stem. Unfortunately, fixated with the cement because the quality of bone really was bad. During the reimplantation, we didn't find any kind of pathogen, but it was quite clear because she was being under the antibiotic treatment. After postoperatively, we went for the broad spectrum of intravenously, and afterwards, unfortunately, like in 10 days, she had also again hematoma formation. We had to go for a day procedure, and she followed with antibiotics with antibiofilm activity against MSSA, but also because of the streptococcal infection, it is quite important to use long suppressive therapy with the amoxicillin, because we know with this kind of infection, streptococcal infection, it is characterized with a high rate of relapses, and the success rate of treatment is quite really effective with the suppression therapy with amoxicillin for 1 or even 2 years. When the patient stops taking amoxicillin, a relapse goes immediately, like in a few weeks. Another case also with a huge history of the polytrauma young guy who had history since 2010, and the pathogen which was found was just staph epidermidis. He came to our hospital with this Gildestone situation. You see the high, huge bone defects, acetabulum defects. We made a debridement, like as I said, we didn't find a pathogen, but nevertheless, we went for the antibiotic treatment for 6 weeks as a preemptive therapy. For here, it took us 8 months for the preparation of the individual implants, and we use it. And during the implantation, we didn't find pathogens, thank God, but nevertheless, we followed our algorithm as for the treatment of the staph epidermidis, and he followed with the LEFO and RIFA for 6 weeks. So this is his X-rays this year of the April. He's really satisfied with the result after these multiple surgeries. He has shortening of his leg, and he was asking about is it possible to make an elongation of his right leg, but we said no, we would like to avoid any kind of further surgeries. And another case, also a really difficult one, the young guy with the multiple surgeries with after polytrauma. But you see, his story starts at 2000 year, and he had this number of the acetabulum revisions, which were succeed only for 1 or 2 or 3 years. Been effective, and all the time it appeared instability of the ends from the acetabular side. You see how many cup changes, Mueller rings, like cup, the TMT cup with augments and etc. and so on. And finally, it was a Gildestone situation. We assumed it could be also a culture negative infection. We should not forget about that. And for these guys, like for others, their individual implant is considered to be like a last option, what we can use. And also we followed our algorithm for the infection treatment for the like a culture negative infection. He followed with broad spectrum antibiotics, but also after implantation with antibiofilm activity. So in my conclusion, I would like to say that the huge bone defects, they are mainly caused by polytrauma, but then also previous infection cases. And they successfully can be managed with their customized patient-specific implants. We should not forget about culture-negative infection, which can be diagnostic with the modern methods also. Can be applied, and in those cases with the individual implants, and also like to protect our implants, we go for antibiotic treatments. And so cases like of streptococcal infection, we don't need to forget about the possibility of the suppression therapy. Thank you so much for me. That's it, what I would like to say.
Thank you, Olga. Very interesting cases, very fascinating, very challenging, addressed very well. One question, obviously this is computerized and you have custom implants. Now, when you actually accurately place the custom implant, obviously you've already preset the screw holes for your implants. And
Yeah.
so
Yeah.
do you know exactly how long those screws are going to be?
Yeah. And that's
Can you
probably
actually say, this is a 35 millimeter screw, you're going to put it in, and that's it?
And that's
Fantastic.
it. It's really, so, I mean, the company say what kind of screw how they should be long, at what, where should I put the screw first, the second, the third? It's quite easy. And I would like to say it's much more easier to manage with the 3D individual implants compared to the cup cage or the cage with augment and the infection bone graft. So it's easier.
Yes, it's certainly better than guessing exactly what length of screw it is and finding you're in the pelvis.
Yeah.
Any other questions, guys?
There's a question from the audience. It's how can a 3D printed implant with graded porosity be designed to replace the proximal femur and prevent stress shielding after tumor resection?
Okay.
Wants to answer?
Honestly, from my side, I'm not dealing a lot with the tumor cases. Sorry. And if for, I should be honest, I never use like individual implants for femur, only like mega C, standard tumor implants, like standard one, but not like individual. So sorry, I have no experience about this. In a tumor case, in the stress shielding, maybe it's not a huge problem. When we treat tumor case.
It's my impression too. Probably we have a lot of options, including the total femoral replacement to solve and without needing the 3D printing or a custom made to do the femoral part. Just in order of time, Dr. Choon, could you present the fourth speaker?
Okay, Abhay comes from Jodhpur. That's where the baggy pants come from. And it's a very interesting place. Abhay is going to be talking to us about up and out acetabular defects.
Thank you, David. And thank you, Nico. And David, you're going to love this one because this is right up your alley. We both have talked so many times about this. So guys, when you talk type 3 defects, you have these kind of situations. The one question that we're always asking ourselves is, what is the simplest second surgery you can give to your patient? And by that, we mean the simplest revision surgery after whatever we do with these situations surgically. And when you're actually talking of defects, you're essentially looking at the exact location, extent, type of defects, and trying to analyze whether the quantum of residual bone that you have, the quantum of residual column support you have for the cup you want to put in, and the residual rim, if at all something is left behind. And that's where these classifications come in. And that's where we have started walking into what Vishnu so beautifully demonstrated, custom tri-flange implants and 3D printed implants. The most important thing we have to do is to find out how much defect, where is the defect, and what is the direction of migration of these primary cups which have gone bad. So you have a 3A, which is an up and out defect, where the amount of shifting of the central rotation is about 2 to 3 centimeters. There is significant teardrop lysis. The ilioischial line is intact. The ischial tuberosity has some lysis, and the columns have a significant superolateral defect. You see this patient who had an untreated, neglected 11-month-old acetabular fracture and had the acetabulum going not only medially but more superiorly. And this is a patient who had a shifting of the center of rotation both superiorly and medially a little bit, but had ischial bone loss to the tune of about 15 millimeters or slightly lesser. On the contrary, this is a case which I'm going to discuss a little more in detail, where the acetabulum and the cup actually walked in, and this patient continued to walk on this through COVID, and this kept on increasing till it landed up just abutting the internal iliac system. And this is when he came to us. So what do you do and how do you analyze these hips? So the basic thing is knowing what is happening to the center of rotation, which is going proximally and medially, and as a consequence of where, because of the patient walking on this hip, you have teardrop lysis and ischial bone lysis. So practically we have nothing left to work on when we are treating with these defects. And these are very significant problems, because again, the question we are asking ourselves is, what is the second best surgery the simplest one the patient is going to need after the reconstruction? And the one standout information that we get with such significant defect is that anchorage of a primary hemispherical shell is not possible. And a lot of times these present with a pelvic discontinuity, sometimes without a pelvic discontinuity. So those who present without a pelvic discontinuity, a biologic fixation has the best possibility of regrowing bone and having a simpler revision whenever needed by the patient. And this is where the custom triflange implants come in, and this is where you use revision shell with trabecular metal augments. And the other thing that we use extensively off late is the customized augment used with revision shells. So you get fixation not only in the ilium, but also in the ischium and the pubis, and you have the customized augments to fill in defects where there are. But you also could think about non-biologic options, which were very popular till some time back, till we actually started getting the engineers making these 3D printed cups for us, which were not very expensive and which the normal common man could afford. On the other side, when you have a pelvic discontinuity post an acetabular fracture, it's an acute discontinuity. The beauty of this discontinuity is that it has biology. So you can just put in a posterior column plate and put in a primary hemispherical shell or a revision shell, and this will work. What happens in a problem situation is a chronic pelvic discontinuity where the biology is not working. And there you need to give it biology, which can be given by custom triflange implants using distraction techniques and customized or prefixed or pre-made augments. Also, you could use some non-biologic methods like cup cage constructs for these situations. And then, as Olga so beautifully demonstrated, you have these double cups, the cup in cup and the cup on cup kind of fixations, which do work contrary to what we thought when we were actually going and doing our initial patients. So let's walk into a case. This is a 47-year-old male. He was housebound because of this problem that he had. He had a fracture dislocation at the hip, which was treated with total hip arthroplasty. And this is what he presented to us with. And as we did a radiological workup, he actually turned out to be an up and in defect, which means that he had a superior migration of more than 3 centimeters, a medial migration of more than 2 centimeters, and ischial bone loss of more than 15 millimeters. So he practically had nothing we could work with. So not only was there loosening of the prosthetic component, he had a slow gradual migration. So we had to rule out septic loosening and make sure there was no infection. So it needed a clinical and radiologic workup. Olga put a very important point there, that all these hips need to be worked up for infection. And then you need a 2D, 3D CT scan and a CT angiography to rule out how close these implants are to vascular structures when you're thinking of surgical reconstructions. And then what is the safest method to remove the component? restore the bone stock. And this is where David's magnificent technique of impaction bone grafting will come into the picture, and do a stable pelvic reconstruction with restoration of the horizontal and vertical offsets and put the hip back to where it belongs. So the other thing that is very important to ascertain is that what is the degree of spinopelvic motion, and that can actually have a bearing on whether you will use a dual mobility cup or not. And very often we tend to use dual mobility liners in such situations. The other investigation that was very important was the CT scan, which showed us the acetabulum, which was absolutely ballooned inside and almost sitting on the internal iliac vascular system, and very close to the external iliac vascular system as well. And this is the picture that you will see. So he didn't actually have a frank pelvic discontinuity, but he did have break in the very thin cortical shell that was left inside the pelvis. And we got these distances measured. On the axial plane, he was about 1 centimeter from the external iliac system. On the coronal plane, about 0.3 centimeters, and so on the sagittal plane. So basically, he was not pressing onto any vascular structure, and he did not have any significant stenosis to any of the lower limb arteries. And that is where we got in the engineers, and they made these bone models for us to assess what is the quantum of bone we have left and what is the kind of implant that we would like to do. And just to walk you through the basic planning of what we wanted to do. So these are the pubic screws that we would like to put in, and they had about 3 or 4 holes here in the pubis so that we could get some screws in there, and some ischial screws, which were essentially kickstand screws to prevent an abduction failure. And it is these screws which are on the augment part of the acetabular socket, which would actually go towards the SI joint, and these are the screws which give the maximum fixation, in addition to the screws from inside the cup. So all in all, this looked like a pretty decent thing to do. And the size, the cup to about 56 on the 3D plan, which we increased to about 60 because we were anticipating some more bone loss because of fibrous debridement of the cup. And of course, this is what saves our lives and prepares the patient for the best possible revision whenever they do need it. And that is impaction grafting. So whatever space is left behind gets filled up and impacted with solid fresh frozen allograft. And this is what is going to fill in bone. And that is what we did. So we were able to retrieve the cup, and we were able to put in both structural and impaction allograft. And we kept on packing this till this time we came to the size where we would use the custom triflange cup, which we did. And we put in these screws, and they were size 60 and 64 and 60. And these was also a size 45. And we were not able to put in the pubic screws, but we were able to put in the screw into the ischial tuberosity. So that gave us really solid fixation, and this cup did not move with a very strong attempt at rocking this cup. And then we cemented in a liner into this as the acetabular reconstruction, and put in a distal fixing stem, which was a Wagner. And this was the reconstruction that we got post-op. So you see, all this is impaction graft. And this is the transparent view, and this was the X-ray view, which we had. And we did some fancy jargon bone mapping of what we had done and where we had planned to put the screws initially and where we were actually able to put the screws. And this is a video showing where exactly we had planned the screws and where we actually could get in the reconstruction. But it actually does not make so much of a difference because you can actually cement in a dual mobility liner inside this acetabular shell. So a little bit of variation from the original pre-op plan doesn't harm your reconstruction. And when we did this assessment from the contralateral side, we realized that we had done a very good reconstruction. The only thing, and fingers crossed, was that this hip the bone should form, and this hip should be good enough for him to bear weight. And this was the patient at 3 months of follow-up. And as you can see that this guy is forming really good bone. And that is the beauty of impaction bone grafting, there where there was nothing to work with. We are going to build solid bone so that once this hip fails, whenever it does, we can actually just go in and do a primary dual mobility cup and walk out. And this is very, very comfortable. And this guy at 3 months was pushing us to allow him to ride a bike to work, which we had to dissuade him to do. And this was him at 9 months of follow-up. We asked him to send this picture yesterday, and this is him. He's formed beautiful bone. His hip is lasting. He's able to do everything, walks without support, and is able to carry out all his activity of daily living. And this is a patient who's very happy and who will need a very simple cup revision whenever his hip fails, if it does. So the basic planning for a revision in such cases is assessing loosening, deciding on whether it's a slow or an acute migration, doing a very thorough clinical and radiological workup, infection workup, as Olga so beautifully pointed out, CT angio, as Marin showed us. What is important to identify is safe component retrieval, making sure we recreate bone stock, and doing a good pelvic reconstruction. So the take-home message is, you have to decide the size and the shape of the defect before you can actually plan what kind of reconstruction you do. And you have to know whether your hip has pelvic discontinuity or non-discontinuity. So custom triflange is a very good biologic way of dealing with these situations, especially if you can do an impaction bone grafting with them. And we welcome you all to the beautiful city of Jodhpur. And David is visiting Jaipur in February. And I'm sure he is going to find some time to make a trip to Jodhpur as well. Thank you.
I've already been there, actually. It's a very nice place. Well, thank you so much. I mean, very well done. Lovely case. And nice to see how all that bone forms.
Absolutely.
It's an amazing thing. Impaction grafting is just an amazing thing.
And what was actually very significant for us was that we've done some double cups and cup-on-cup fixations, and the custom triflange with impaction bone grafting seemed to throw amazingly good bone and very fast, and that was amazing to see.
Yeah. Okay, well, we're kind of running out of time, so we'll move on to Louis, who comes from Queen Mary Hospital in Hong Kong, and he will be telling us about his experience with 3D implants.
So thank you, David, for the introductions, and thank you, SICOT, for the kind invitations. It's always great to come back to SICOT because I was a past SICOT committee council member working with Nicolás. So today I'm going to share some case examples to illustrate some of the principles behind the custom-made processes in some of the complex situations. Let's go to case one. Case one is a 72-year-old gentleman's history of psoriasis and then history of right hip avascularitis with multiple hip surgeries done and then 2 revisions, but the cause was not sure. It was told to be infections. And then later on, these patients really complicated with infections, with repeated debridement done, and then having the lifelong antibiotics. So this case was referred to me by another country, and then this is an X-ray on arrival. You can see here the cup was put in high hip center with an ointment, and then from other X-ray view, you can see there's a definite radiolucency between the ointment and then on the host bone. So this is the case referred to us, and then initially we definitely need to do our infection in this case because of the underlying risk factor of psoriasis on biologics and then history of infections. Despite multiple workup as shown here, blood tests, CT or image guided aspirations, even we send some of the fluid, we try to send some of the fluid for investigation, but it knew nothing. It seems that doesn't have any hint of infections. So this is, as discussed by Abhay, this is up and out defect, 3A Papowski. So this is, in conclusion, this is the scenario we have. So big defect, 3A, psoriasis, and the heat-shift right total hip infections. So we discussed a lot about this case because despite the extensive pre-op we did, we still worry about infections because we don't want to put in a very complex reconstruction inside and then later on complicated by infections. So we have a very safe approach for these patients after a series of discussions. So we do a spaces. We take out everything. This is we do an ETO to extract the stem, and then eventually we put in a cement spaces, and then interrupt multiple tissues, no growth, and then we have a very exhaustive tissue sampling in trial over acetabular side and femoral side, but it knew nothing. And then we also send it for next generation sequencing molecular technique. It doesn't yield any bacterial infections, and then it probably it have a very good reassurance that it's not an infected case, and then we plan for the second stage surgery and then reconstructions. So this is the bone, the CT scan showing a very poor bone support over the acetabular side, also a lot of bone defect. These are the different reconstruction options we have. 1.5 stage. We can use the off-shell pod like the post-metal almond, cupcake construct, or the custom-made tri-flange. So after discussion, we decide to use a custom-made tri-flange. So this is the CT scan. We send it to the company, and then we have to decide. So I think initially, I think that one of the presentation is great. In general, the 3D printing process involve imaging, converting the DICOM image to the STL data, and then design with the engineer, and then later productions of the prosthesis. So this is the process. So in general, I think one of the key thing, one of the most common encountered hiccups is discussions with the engineer, because the engineer most of the time mainly plan the prosthesis according to the biomechanical principles only. So they ignore the soft tissue, but I think this is one of the key things. So usually when we discuss with engineer, we need to plan the tri-flange where it will going to sit on the host bone, and then how many screws we have, and then this is the discussions. But most of the time they plan it very bulky. To an orthopedic surgeon, it's very hard to place it in, despite we use a very extensive approach, ETO. But I think we need to strike a balance, because whenever I have discussions with engineer, they make the implant very, very bulky, and then this is very difficult to be placed. Moreover, the iron flange, we need to place a very bulky iron flange. I think sometimes we need to dissect the iron. It can have a potential superior gluteal artery damage, or moreover, we even have a superior gluteal nerve damage. So that's the reasons why it's very common to see patients still walk with a limping gait after surgery. So this is one of the important things. We need to have a close discussion with the engineers. So this is the plan we discussed with engineer. We decided to remove minimum bone because already a lot of bone loss. So we want to remove minimum bone, and then in order to sit the implant, this is the guide for us to remove the bone, so that our implant can sit comfortably on the host bone. And then this is the tri-flange component we put in. So I think one of the key things when we decide that tri-flange component, we want to have a good stabilities for the implant, for the custom component. So it's very important to have locking screw, because this kind of locking screw is going to give you a multi-directional stabilities. You put as many screws as you can, pull over the ilium, ischium, and pubic rami in order to enhance the stabilities. And then moreover, you can design the post coating in some of the strategic areas so as to enhance the bone ingrowth, because these are the areas having host bone contact. This host bone contact for the bone ingrowth, that will be very important for the long-term stabilities of the custom-made prosthesis. So this is a very bulky prosthesis we need to put in. So despite we use extensive approach, sometimes it's very difficult to put in, and then to orientate ideally as we plan. Most of the time, apart from the adductions, the rotations of the component is very difficult to be orientate exactly as what we plan. So this is the final product we have, and then luckily we can put in as where we plan. And then you can see here, I also use extensive approach during the exposure, and at the same time I also revise the femoral stem. So this is initial post-op X-ray, and then finally the ETO also healed, and then so this is a post-op 2 months. The patients can already tolerate full weight bearing walking without any pain and have a very satisfactory outcomes. So another case, I think David also mentions very important in the tumor case. So this is a very malignant tumor, post-radiation osteosarcoma of the pubic rami. So the tumor surgeon come in, excise the tumor. Initially, they plan to have a hip perforation surgery. But so you can see the femoral head still remain there, but later on, the posterior column break. So, and then the femoral head medially protrusive. So they asked us whether this is any good tips for the reconstructions. You can see extensive bone loss as shown here is very, I think, very, very difficult to be reconstruct with the conventional prosthesis. So here we decide the custom prosthesis. This is the 3D planning we have. So we excise the original femoral head and then to use that as an autograft. And then later on we have this is not triflange, it's a biflange because the pubic rami already excised out. And then we plan the screw to fixations over the ilium and remaining ischium. The bone graft, we also put a screw the femoral head across the femoral head, and then fixation of the femoral head towards the ilium. This is what we plan for these compact solutions. So this is the final product. So you can see here, this is one of the post-op X-ray at around 1 year. The femoral head already united to the surrounding bone, and then the patients can walk quite stably with this kind of construct. So this is a post-tumor excision reconstruction that is also very useful for the applications of the customic component. So just have a brief word about customic component. So when we need that, I think the simple answer is when the bone cannot be reconstructed by using the standard implants. The customic implant will be very useful to best fit to the patient's host bone and then to improve the surgical outcomes. So some of the examples as shown here, revision total hip, massive ascending bone loss as discussed by Abhay, and also tumor excisions. After tumor excisions, we have a large bone defect. How do we reconstruct the bone defect? It will be very useful also in the tumor reconstructions. Also, another very good example, especially in our Asian anatomy, because sometimes the bone is very small, very deformed, and then because deformity may be underlying metabolic disorders or osteogenesis imperfecta, and then this kind of situation also very useful for the use of the customic prosthesis. So here is one of the paper published. It showed, I think, one of the longest follow-up period for the customic prosthesis. This is up to 10-year follow-up. So this is 42 cases, 41 patients, and then average follow-up of 10 years. The survivorship of the CT-AC is good, up to 95%. So the survivorship is at least as good as the conventional techniques such as jumbo cup case construct. But I think in their series also they report some of the complications, like the instabilities of customic prosthesis and infections, because I think this is the newer designs. I think with the more updated design with the use of locking screw that make the stability problems partially solved. So here is a review of the published in EFA open reviews. This is meta-analysis. They show the newer generations of the CTAC. Actually, the complication rate is a little bit lower when compared to older generations. I think one of the important things is the locking screw, and then enhance the porosity surface to enhance the bone ingrowth. But some of the important techniques, according to the personal communications with the some of the authors using these techniques, I think the long-term stability still depends on the host bone contact with the post-coated surface. It's very important to enhance the host bone contact. And moreover, sometimes the position of SICOT-APHS is difficult, so you need to extend the exposure. If you have navigations, it's good also to have navigation to guide the prosthesis placement according to the original plan, because sometimes the prosthesis is very bulky, so just slight variations with the orientations of the component, you cannot put in the screw to the direction you want as in your plan. And then stresses, once again, it's very important to have locking screw to lock the component towards the host bone. So I think the potential concerns with the custom component is a position time, as discussed. At present, still at least 6 to 8 weeks for the turnaround time from the design to planning to the manufacturing. Cost is also a concern. It's great to know about the Indian company producing very good custom-made prostheses. Probably can make the cost much more reasonable than productions probably from the developed countries. And then for custom-made prosthesis, there's a low in shop modifications, because once you produce the metal, you need to shrink the patient's bone to fit the prosthesis. So this is sometimes that is also difficult, because you don't want more bone loss in some of the difficult revisions. But it's important to remove those bone in order to sit the prosthesis to maximize contact with the host bone. So also material limitations, and then regulatory considerations, and also limited clinical data to show the long-term survivalorships. So here's another case I want to show to you. These patients also suffer from high-grade osteosarcoma. So these patients, we discussed with tumor surgeon, because of this is a very malignant tumor. So we decided don't wait for the custom-made prosthesis, because waiting for 2 months, the patient may even have a poor prognosis. So as a result, we use the conventional reconstruction. You can see here, we use the two augment to reproduce the anterior column, and then put in tantalum cup, and then also have a good screw to enhance the fixation. Sometimes if there's a very malignant tumor, it's no point to wait for the productions of the custom prosthesis. We are forced to use those conventional reconstruction. So also, I think although with the advances of the conventional the 3D printing prosthesis, we also need to probably stick to conventional technique, because sometimes the conventional technique is also important if you don't want to wait for the custom-made prosthesis. So any future direction for the custom prosthesis, there will be going to be improving material to enhance the bone ingrowth. Moreover, there will be also antibiotic can be diluted out from the prosthesis. Moreover, right now the design process is still quite lengthy. We hope to have a standardizations in our course talk with our engineer, and then to streamline the workflow, and in order to shorten the time for the manufacturing. So here's the conclusions. The 3D printed custom prosthesis is going to be very useful in some of the very complex situations, such as severe assembled loss after tumor excisions and patients with unique anatomy. So with in decreasing cost, much wider applications, I'm sure this is one of the future in tackling those complex hip pathology. So with that, thank you for your attention.
Thank you very much, Louis. I think you and I have learned that the place to go for our patients is India.
And
we'll send them all to you, Abhay.
Just to let you know, the time from when we order and send the CT scans to these guys, they come back to us within a week, 10 days max. And you do your final jugularly, approve the and you have the component within 2 weeks.
Do they ship?
And the cost is less than 15?
Oh, it costs what? It costs what a dual mobility and a Wagner stem would cost in our country. That's very reasonable.
Perfect. In Argentina,
sometimes standard revisions cost more.
Have a lot of in Argentina they have a lot of experience with custom made, and it's like in India, quickly and quite cheap.
Yeah, the cost sometimes will also depend upon the quantum of material they have to use.
We are running out of time.
Yep, I think we have run out of time.
Pardon?
So thank you very much.
Thank you, David.
Thank you very much.
From my point of view,
all the
being a
speakers.
powerful collaboration. Thank you.
An excellent talks with a difficult program. Thank you so much. Bye-bye.
Thank you. Bye-bye.
Thank you, David. Bye, Lewis.
Thank you, David.
Bye,
Thank you,
Vishnu.
Bye.
Bye.
Bye. Bye-bye.
Take care. Have a good evening.
You too.